Thank you very much. Mark, thank you very much for asking me here. I feel very flattered and very honoured to be able to talk to all of you this afternoon. This is a really vast topic, and I've got quite a short space of time in which to cover it, but it's a topic that I'm passionate about. I think it's crucial that we offer an excellent shared care service. I'd like to talk to you a little bit about my shared care service, but also to show how we can offer it as a sort of uniform service across the whole of the country. So for those of you that don't know me, some of you I do know faces sitting here, but I work at Barnet General, a district general just up the A1. It's a relatively new build. It covers a lot of adults, and we have a paediatric unit. Now, some of you might think, well, it's sort of great because children become special there, but obviously we're also trying to cover a huge adult population, and as we've heard in the earlier talks, cancer in adults is so much more common than cancer in children. And I think sometimes in the district general setting, people can forget that we exist. And certainly where I've worked, up until only a couple of years ago, really, people came up to me and said, oh, I didn't know that you looked after children who had cancer. So I think it's trying to sort of highlight that we are all actually here. I'm showing you a bus there because one of the pitfalls of working at Barnet General, and certainly if you're a parent and a patient, is that you can never park and you may rather come on the bus. But I also work here, so I think perhaps I'm quite fortunate in being able to talk to you about what it's like on both sides of the fence. So I work in a tertiary centre, what is known as your primary treatment centre, your PTC, and I work in a POSCU. And so actually I have first-hand experience of what it's like on both sides of the fence, and some people may think that the grass is greener on the other side, and certainly there are pros and cons on both sides. So what's the aim of my talk? Well, I would like to ask the first very large question, really, of why? Why do we need a shared care centre? Some of you might think, well, we don't need one because people have got a primary treatment centre, so actually we don't need one of those, and I'd like to persuade you that everyone very much does need one. Again, it's a huge topic, as I've said, so I really want to give you an overview of what we do within the shared care world. And perhaps to ask you the question, I've answered it and I hope I've got it right, but what do you want from a shared care hospital? And once we've realised what you want from that, how do we go about providing that service? So why? Do we all need one? The cynic in me would perhaps say that some people might say, well, we don't really need one, because actually, wouldn't it be lovely if all children could be treated in a tertiary centre, and actually it's just a sort of overflow of bed capacity, and we need to ship parents and patients out when we haven't got room to look after them from the problems that giving complex chemotherapy gives. But I think it's much more than just that. Okay, there is a bed capacity, but actually I would argue very strongly that what parents and patients and children want is they want expert care delivered as close to home as possible. And throughout my talk, I think you will see these phrases, these two phrases really coming through again and again. And I think those two words are crucial really. There's expert, and clearly we all want to have our children treated by people who we feel confident that they know what they're doing. But equally, isn't it lovely to have that care delivered as close to home as is possible? And perhaps that's not always the case, that your local hospital is going to be where you're going to get your shared care, because that may not always be able to give the most expert of care in all cases. So, the overview of what we do. Different shared care centres will do things in slightly different ways, but there are now very uniform standards, and I would just like to go through how that expert care is given. Now, Amos has poached some of my slides from previously, but just to go through some of the terms, because obviously I can't top Amos's abbreviations, but we have a few. So every child who has a diagnosis of childhood cancer made will have a primary treatment centre. And the purpose of that centre is to diagnose what is wrong, to make an initial treatment plan, to have important conversations about any changes in treatment, how treatment is going along, and also to give the more complex treatment, bone marrow transplants, stem cell transplants, etc. But then we have the POSCU who work alongside the primary treatment centre. And within that, our country has divided us into level 1, level 2 and level 3. As touched on earlier, level 1 provides in and outpatient supportive care. That's a phrase which covers an awful lot of care given, which I will explain a little bit more fully. We also provide outpatient follow-up, outpatient oral and intravenous bolus chemotherapy. Levels 2 and levels 3 offer everything that level 1 also offers. But level 2 can do chemotherapy given via a drip on a daycare basis, and level 3 can offer it over a 24-hour period for those people that require inpatient chemotherapy, with the option, with the agreement of the PTC, of sometimes doing lumbar punctures with intrathecal chemotherapy. So, what is the POSCU role? Clinically, let's start at the very beginning. So we are often, or pretty much always, apart from going to your GP, we are the first people in the first port of call to have to break that bad news. And that's a crucial point. Up until then, people, parents, children may not be aware that there's anything wrong, or they may have an inkling that there's something wrong. And clearly this first meeting point plays a crucial role in how parents and patients will view your shared care centre in future months and years. Supportive care. This is our bread and butter of what we do day in, day out. We then we will look after everything that happens following being given a complex course of chemotherapy. Looking after children who have fevers, are neutropenic, require blood products, may need nasogastric feeding because they don't want to eat, making sure they have adequate calories. Yes, we give chemotherapy, but I would argue that's almost a pretty minor role of everything else which we do. We run clinics, on and off treatment clinics. So we will see people during their treatment, perhaps to monitor how their oral chemotherapy is going, to give simple intravenous chemotherapy, and also seeing people and patients and parents once their treatment is finished. And that's where we develop a real rapport. This relationship develops over many months and years, and there's a huge element of trust which also builds up, and I think that's crucial to many families. And again, I think that's why it's very crucial that this is all delivered as close to home as possible, knowing that there's someone there, that there is a team there that parents can call if they're anxious about something. We also run long-term follow-up clinics. These are slightly different to the off-treatment clinics. These are for when patients are more than 5 years following the end of treatment, and we deem them cured. We no longer focus our concerns about the possibility of the disease coming back again, but turn our concentration to looking and monitoring for any late effects that may have been given by previous treatment given in order to cure people. Palliative care. I mean, clearly this is something that hopefully we wouldn't ever need to go there, but unfortunately, yes, we do. And I think it's very hard to deliver good palliative care if you haven't built up a rapport with patients and their families prior to this. I think having nurtured them and seen them through their treatment, it makes it easier to guide them through this just horrific journey that they're going through. Psychosocial support. Last but not least, I think this is an ongoing process. I don't have any trained counselling myself, but every day I will be counselling patients and parents the whole time, as well as having qualified teams working with me. So how do we do this? I've shown this slide really just to point out that, goodness, there's an awful lot going on. How do we work with the PTC and with our shared care POSCU units? Please don't focus on it, because I can't it's sort of blurring, isn't it, really? But what I want you to see, really, is that there are arrows, and there are arrows going both ways. And it shows, really, that what is crucial, and I think people have talked about this in previous talks, is that it's utterly crucial that we all communicate with each other. And that's communication between the PTCs and the POSCUs and parents and patients and children. I like to make that into a little bit more of a simple slide, so this is my version of it, which really shows that central, you have the primary treatment centre, but within all of that, you've got different level POSCUs, and everyone needs to be talking to each other, and it's a sort of hub and spoke approach. Communication is vital. When looking at this slide and choosing this, I thought, gosh, yes, I've been there many, many times, but it's not just healthcare professionals who are on the phone trying to communicate, trying to get answers, trying to know what is going on. This is equally relevant and apparent to parents, I'm sure. And I can't stress enough how important to our whole service and looking after children, we all need to talk to each other. Just a little bit about where our POSCUs are and our PTCs are. I think we've had slides that look quite similar. But when I mentioned earlier that what it may be that your local POSCU is not the one that is closest to home, you can see that if you live in the southwest of the country here, there are a lot of level 3 POSCUs. So they are ones that will offer 24-hour chemotherapy. Because actually, if you can't have that at a local POSCU, that's a lot of travelling. Whereas actually, in the sort of M25 belt, there are huge numbers of level 1 POSCUs for your PTC. And so there is a rationalisation and an argument that actually we should centralise those POSCUs to make them bigger, more experienced, perhaps aim for having more expert care. And because obviously, if you only have 3 or 4 patients a year who you look after, you can't hope to carry on being the expert. You need to have a crucial number of patients who you look after. Expertise, that's required. As I said, your POSCU may not be always closest to you, but what we want is expert care as close to home as possible. So I'm banging on about expert care, but how and who determines what is expert care? Is it enough for me to say, well, I'm trained and I can do this and I'm wonderful? No, it's not. There are many people here who will have been clutching this manual as their Bible for months and months. There are now national standards to review cancer services, both in the adult and in the child world. And I certainly, a few months ago, was carrying this around on a daily basis, referring to it. Within this, there are standards which we have to show that we adhere to, that we comply with, and we have to prove that we fulfil the standards which are set. As well as that, it's on a website, and we have to upload our data onto this, and people can log on to this website to see how your local district general is doing and how we've all done in the last round. So what's it all about? There are national standards, and certainly in the paediatric world there are about 70, more than some of the adult standards, to be honest with you, that we have to show that we operate according to. We have to write an operational policy, which we have to update every year, detailing how the shared care service works within our unit. On top of that, once a year we have to write a report saying what we've done over the previous year. And also look to what we would like to do in the next year and our plan for the following year. And then we've also been asked to do a 3-year plan, which for me is a bit of a wish list, really. It's what would you like for the next three years? As I said, we have to prove everything that we say that we do. We have to provide evidence for it. And the reviews take place either as an internal or an external review. So once a year it will be internal, and the following year there will be an external team who will come for the whole day and visit your unit, ask questions, look at your evidence. You will show them round. I used to be quite cynical about this because actually it's a lot of work. and I would think, well, okay, I can show you what my service is and I can prove to you what I've done. But actually, if I don't manage to fulfil all of the criteria that's required of me, who will help me to ensure that I can do this for following years? And I have to say, over the last couple of years, I have changed my opinion, because by putting your head above the parapet to the adult world in your district general, and by showing what you do, and showing what you do well, but equally showing what perhaps you haven't got the funding for or the ability to do because of resources, you can highlight how you want to make your service better. I work part-time, and I had a part-time nurse, and as a result of the review process over the last 2 years, I've now got a deputy, a full-time nurse. My lead nurses have much better training, and gradually I think things are getting better. Yes, we give chemotherapy, and some of these chemotherapy agents will be familiar to all of you. But as I said before, I think it's much more important than just giving chemotherapy. Off-treatment follow-up, we will also have the ability to provide some of those routine investigations that you don't need to go to your tertiary centre for: chest x-rays, ultrasounds, heart scans, long-term follow-up, psychosocial support. It takes communication and it takes a team. You can't do this just with a team of one person. And actually, I could spend half an hour talking just about this slide, actually, because the community nursing team for a shared care unit are crucial. The community nursing team go out to parents and children's houses, they go on school visits, they may take blood tests at school to try and encourage children to be able to lead as normal a life as possible. And as well as doing that, as maybe giving some antibiotics at home, they will support families through their journey. There's a lead oncology nurse within each shared care unit who is the sort of key point of contact if there are any queries or questions. We clearly need skilled ward staff and facilities to be able to send them on teaching and training courses and keep their skills up to date, because it's no good having a wonderful outpatient service. But when children come in with a fever, the ward nurses clearly need to be able to look after them as well. And obviously the rest of the team, dietitian, play therapist, psychologists, the list is endless really. What else do we do? Well, our home care do home visits. I personally, if I'm not going to see new patients early on in an outpatient setting, I always try and do a home visit right at the very start, because actually when parents and patients have to come in for the first time when they're ill, when they've got a fever, it makes it much easier if they feel that they've met some members of the team before. And of course then there is end-of-life care if things don't go according to plan. We can also put patients and parents in touch with local support groups and help them with access to local services and charities. One of my parents recently held a charity ball which I went to, and it was a humbling experience listening to her talk when she was talking about us explaining that she needs to carry on with living as normal a life as possible. And we all say that. We say, well, you must try and live a really normal life. It's impossible, isn't it? I'm sure it is. And she said that the one time when she felt she could try and get on with leading a normal life was when someone from Noah's Ark came in to do the ironing for her, just because then she was able to go out for half an hour and go off to the shops or to get her hair done. So it's support for parents, it's support for their children. Remember siblings as well. We always talk about leading a normal life, but it's the parents and the siblings who all have to try and do that and to involve them as a whole family. And sometimes it's the little things that can make a real difference. For example, if a sibling's coming in with their brother or sister when they're having their chemotherapy, let them hold the blood bottles, show them where the laboratory is, just involve them, and that can make all the difference. So in summary, I hope I've shown you that shared care is exceedingly worthwhile, that what we aim to do is to deliver expert care as close to home as possible. But in order to deliver expert care, it might not be the hospital which is closest to you. Very reassuring now, I think, is that there are very stringent guidelines in place and we have to adhere to them. We have constant reviews of services and feedback as well. And this is not just from healthcare professionals, but we have parent questionnaires, we have audits to constantly try to improve our services. It requires a team who work very closely with each other, with parents, with children, and with the PTC. And I can't stress more that communication between all of us is key. Thank you for listening, and I believe questions will be at the end.